So I would like to introduce the last speakers from Taiwan. Professor Huang Meng-Chuan. Professor Huang now is currently the professor of the Department of the Public Health and Environmental Medicine in Kaohsiung Medical University Hospital. She also is the director of the Department of Allied Health Training, Personnel Training. She is the vice president of the Taiwan Dietitian Associations. Now that today he will give us a talk entitled it's a retrospective the observational studies in assess the impact of the multidisciplinary the team care and the nutrition education on post-stroke patients at the risk of the dysphagia. Let's welcome Professor Huang.
Thank you so much for very kind introduction on me. And thank you for Dr. Xi to invite me to be here to give this little talk. And actually, this study coming from a routine work of a dietitian. And this is a cooperation of many different health professionals to make this happen. And I would like to talk about a retrospective observational study. This study is aiming to evaluate the impact of multiple disciplinary team care and also the nutrition education delivered by a clinical dietitian on primarily post-stroke patients and they're at the risk of dysphagia. And I'm coming from Kaohsiung Medical University and the University Hospital. Let me give you a little bit introduction. Also to let you understand that what kind of specialties that the dietitian will visit the patients. And the dysphagia is a disorder characterized by difficulty in chewing and swallowing foods, primarily due to disease status, aging, or other causes. And apart from a natural aging process, some diseases can easily lead to dysphagia. And these diseases include cerebral vascular diseases, neuromuscular diseases, cognitive dysfunction, cancer, and also sarcopenia. As we see from this report, there are patients were tested using the E10 scale to test their dysphagia status. A greater portion of the dysphagia risk are seen at the specialties such as pneumology, internal medicine, cardiology, and also neurology. So it means that if the dietitian are appointed to visit patients at these wards, they will see more patients with dysphagia problems. Okay, and let's look at the impact of stroke. A stroke is one of the leading cause of death and the disabilities, and its economic burden and also medical burden actually has been increasing over time. The major complication after stroke, including some nutritional problems, which include dysphagia, some gastrointestinal disorder, and also some infection problems, including pneumonia, urinary tract infection, and seizures, and so on. And now I would like to talk about the relations between dysphagia and the malnutrition. Actually, the dysphagia is one of the major problems with patients with acute stroke. And this may affect more than 50% of the stroke patients. In some of the clinical practice that we will see that most of the patients with dysphagia in the acute stroke phase would recover swallowing function maybe within a week. However, there are some patients have encountered prolonged dysphagia and would not be able to eat properly. So dysphagia affects abilities to swallow safely and efficiently and cause difficulties in consuming an adequate and also balanced diet. And for the long run, this problem is going to cause malnutrition and affect the quality of life for later quality of life for their later routine life. And now I would like to introduce some of the papers published in Asian countries to probably report some of the malnutrition prevalence among dysphagia and the non-dysphagia patients. And this study actually is done in Vietnam. It's a large hospital, including 1,007 older inpatients with the mean age of 76 years old. Let's look at the overall data. For this group of patients, that the prevalence of risk of malnutrition is around 54%, and for the malnutrition is around 29%. But if the patients were confirmed with the dysphagia, we will see the prevalence of malnutrition actually increased to 50.6%, and the patient at the risk of malnutrition is 41.6%. So it means that if the patient with the dysphagia problem, they are more easily to encounter some of the malnutrition problems. And the second study actually comes from Korea. This group of patients actually visited the teaching hospital in Korea for a video fluoroscopic swallowing test due to dysphagia. And we will see that there are 41% of the patient in acute stroke, or 21% of the patient with subacute stroke patients with the normal nutritional status. So it means they are probably around 60 to 80% of the patients encounter at the risk of malnutrition problems. So there's a huge prevalence. There's a huge number of the patients with this kind of problem. And this is actually a cross-sectional study, hospital-based observational study done in Taiwan. And let's look at the malnutritional prevalence around for the stroke patients. So the patients with risk of malnutrition is around 54.1%. For the malnutrition is around 12.1%. So still, in stroke patients, there are quite a number of patients encounter the malnutrition problems. And let's look at the percentage of the patients on NG diets. So for the malnutrition group, the percentage for on NG diet is as high as 40.7%. For the patient at the risk of malnutrition is around 11.8%. And also we will see a lot of comorbidities, underlying comorbidities, including hypertension, diabetes, and hyperlipidemia is actually quite prevalent in our stroke patients. So the nutritional strategies to prevent dysphagia, to prevent the onset of complications of dysphagia, or aspiration pneumonia, and malnutrition and dehydration. I think a lot of common methods is to use nutritional intervention and the education. And thanks for Peter's very thorough introduction on the texture-modified diet. The other strategies for dietitian to use is to teach the patients how to prepare their foods with the texture-modified or the texture-modified liquids. And yet, different reasons, the evidence on the adequacy and the efficacy of nutritional education and the food texture modification for the management of malnourished dysphagia patient is scarce. And the problem is that there are different classification, and also people use different maybe scale or like nutrition screening methods to assess the nutritional status or the progression of the food texture. And the other thing that it has to be brought to attention is that the initiation of the artificial nutrition, which is the tube feeding, is only sporadic in some countries. But in Taiwan, actually the implementation of the artificial nutrition is actually quite high. And this is one of the attention that has been brought by some of the medias and also the medical societies. So the little studies, study rationales and the aims is that most of the observational studies use different scales to define nutritional status and also dietary texture. Also, they render the study results regarding the impact of nutrition incomparable and inconclusive. So this retrospective study aim to examine the impact of multiple disciplinary team care, and the team also provided the nutritional education by registered dietitian, and we primarily taking care of the post-stroke hospitalized patients with the risk of dysphagia. And this analysis actually is done in Kaohsiung Medical University Hospital. Okay, this is our team. The retrospective study actually was performed in 185 post-stroke inpatients. And you can see that in our team, we have many different allied health professionals from different areas, including our nurse, dietitian, our dentist, and also imaging department doctors and speech therapists, and also the rehab doctors. And it's actually a team of multiple disciplinary health professionals coming together to take care of our patient. This is not easy in hospital to coordinate so many different people with health professionals to reform the healthcare protocols. Okay, so this is the dysphagia screening process in our hospital. This process, we have a stage A, stage B, and the stage C. So the stage A was performed by our station nurse. They performed the 3-stage swallowing function screening. If the screening result is abnormal, the patients will go on to the stage B test. And the stage B was actually performed by our case manager, and 3 different types of tests are performed. This include oral health assessment tool, repetitive saliva swallowing test, and also the modified water swallowing test. And as you see this color right here, this is actually the EC color. So we use the EC thickening liquids classification to do the modified water swallowing test. And if the patient got the abnormal test for the stage B, and they will go on to the stage C. So the patient will go on to receive the examination for video endoscopic evaluation and also the video fluoroscopy evaluation. And in this stage, as you can see the test meal right here. For the VF test meal, we also use the EC standards. The reason that we use EC is because it's much easier to communicate with our medical doctors, because the EC has a lot of scientific reports and also the standardization of the preparation and also the tests on the website that we can obtain. And that is one of the reasons in this year, we standardize all the food texture and also all the test regimens according to the EC standards. And in our hospital practice, if the patient was screened for stage B or stage C abnormal, that means if patient is at the dysphagia risk or confirmed with the dysphagia, they were all passed to the dietitian to receive nutritional counseling during their hospitalization. So this is the general protocols that we perform in our hospital. So we collect the data actually from 2020 to 2023. The post-stroke patient received dysphagia ABC screening test. So we have a total of 694 patients. And the screening tests were performed by case manager and along with the speech therapist. And patients were screened for the dysphagia, and they also screened for malnutrition and using the subjective global assessment tool. So after the dysphagia screening and also the malnutrition screening, the patients were classified into 3 different groups. Group 1 is the well-nourished and the mild malnourished patients, and moderately malnourished or severely malnourished patients. The reason that the purple line is right here is that in our hospital, it is standardized that if the patients were screened as the SGA score about 4, they has to be transferred to dietitian for counseling and within 8 hours. And then the dietitian have to complete all the nutritional counseling within 48 hours, okay? And so this group of patients actually continue to receive the nutritional counseling during their hospitalization, and also they will be followed up by case manager regarding the status of their NG tube removal status by 3 months. And right now we are proceeding to follow them to the 6 months. And then if the during the period that the case manager communicate with our patients, if they have nutritional problems, sometimes we'll communicate by the phone, or the case manager will inform the dietitian to discuss with the nutritional problems and then talk to the patient again. Okay, this just to let you know, because their texture modified diets and the thickening liquid actually are quite important, but we need a standard, we need to standardize protocols to make the test meal, to make the foods, and also educate our patients. And then in 2013, the EC just developed and published on the website. So we adopt a lot of materials from the EC website. And I think in our audience, we have many audience, maybe from different schools and also hospitals. I think the Medical Society of Taiwan started to pay attention to the delivery of nutritional education on dysphagia patients, maybe started maybe 4 or 5 years ago. And around 4 or 5 years ago, many people went to Japan, and then they look at the long-term care facilities and also their hospitals. And in the food service in Japan, they use 2 standards. One is the Smile Care, and the other one is the Universal Design Food. So originally, we did look into that, but when we tried to start to implement in our hospital, many people could not read Japanese. So we adopt a English, because the EC has many different language version that you can check on the web. And so starting in this year, we actually just adopted EC in the whole dysphagia screening, assessment, and also food delivery in our hospital. And very fortunately in Taiwan, I remember in 2018, our Health Promotion Administration actually established the food texture classification for Taiwan. And right now, the 30 has e-tenders, and this tender is specifically made for a lot of food manufacturers to be able to follow the standards to modify our diets. Okay, so I just want to let you know practically how a dietitian department how to apply these dysphagia modified diets on our clinical practice. So this is actually the modified water test. So this is our bottle. So all bottles with label with the color, just to make sure that we don't make mistakes. And this is actually the pigment, the food pigment but this is a natural food pigment. So we use this, and this is the VE, and we also have the VF test meal, and we also use the EC standard to do the VF meals. So in our hospital, the nutrition and dietetics department actually have a good cooperation with different departments of our medical services. So all doctors actually very appreciate that we make these kind of foods and the test meals and also the nutrition education materials for our patients. And this is the scale that we use to assess the texture progression of our patients. So we use the SGA to do the screening, and we also do a comprehensive nutrition assessment after we see the patients. And the freeze scale were used to assess the progression of the food texture after we educate our patients. So you can see that it has the 10 levels, and I have the Chinese version right here. So level 1 to level 3 is unable to eat orally, and level 4 to level 6 is the tube feeding along with some of the texture modified meals. Level 7 to level 10 is probably gradually take away the tube feeding and then try to eat orally or freely. So we use these standards to assess the progression of our patients to make improvements in the food texture. Okay, and then after we see the patients, some of the major points that we will educate our patients is to tell them how to look at the standards and how to modify your foods to make the right texture for the patients, and how to increase the calories and proteins. And if you need a oral nutritional supplements, which one is correct. And then we also have to consider their comorbidities such as diabetes and maybe kidney problems and so on. And if the patient were on the artificial nutrition, we also have to recommend what kind of oral nutrition supplement is appropriate. And for the follow-up nutritional counseling, that is the system in our hospital that once the patients were screened for as a malnourished group, they will be screened again on the 7th day and the 14 days and the 30 days after they are discharged. But after the patient were discharged from our hospital, they will be also followed by our case manager, who is a nurse. Okay, and this is the Mandarin version for the nutritional education. And let you introduce you on this. All of these materials are actually online in our hospital website. And so we have different nutritional posters posted on the web that our nurse and our doctors and our patients can download it and they can check it. And for the thickening liquids education, this is the bottle we make on our own. It's we have some manufacturer to make the bottles, and with the EC standard on one side, and on the other side is actually the scale. And then per 200 cc, you use one package of the thickening agents as level 1. If you use 2 pack, they will be level 2. So, and then we have all kind of liquid, the food powders to make the liquids put inside of the bottle. So it makes very convenient for patient to use. And we have the nutritional posters. We also have the videos all posted on our hospital website. Okay, let me show the little preliminary results. It's very small studies, and then I'm not a person in the geriatric nutrition. I work on the diabetes and also chronic kidney disease before, and this is new for me. So among the 184 patients, we can see that it's primarily male. 67% is greater than 6 years of age. 37% with diabetes, about 70% with hypertension. The major disease diagnosis include stroke, cerebral vascular diseases, and also respiratory diseases. And this is a cross-sectional analysis for the person who received one-time nutritional education. So we classify our patients into different malnutrition risk. SGA 0 to 4 is well nourished, moderately malnourished is SGA 3 to 5, and severely malnourished is SGA 6 to 7. So we just want to look at the relations between common nutritional indicators with the nutritional classification. So we see as the nutritional status is worsened, the lower the weight, the lower the body mass index, also the worse of the food texture. The lower means they are more prone to not to be able to intake food from orally. Okay, and then because this is a retrospective cross-sectional analysis, and we did not have a lot of patients with severely malnourished risk score, so we only have 5 people in this category. And across the 3 malnutrition categories, we did not see the differences between the dysphagia severity score, albumin, and also the hemoglobins. And because this study actually were averagely only observed for 14 to 21 days, we have not collected a more long-term data within the hospital. So these are the data I can present for right now. Okay, so cross-sectionally, that we did a nutritional counseling one time for 185 people. And for the people who received 2-time nutritional counseling, we are interested in look at the changes after they received the nutritional consultation. And we see within the observational period, the weight, the body mass index, the calorie intake, the protein intake actually was maintained. So it was not getting worse. So that's good. Because they admitted to an acute hospital, and sometimes it is not necessarily that after they receive 2-time nutritional education, they will make big progress in some of the nutritional indicators. But we did see that the freeze level scores is going down. It went down from 3.7, went up to 3.7 to 5.5. It means they are more able to take the food from oral. Between the first-time nutrition counseling and the second-time nutritional counseling, and also their SGA scores is decreasing. That means their nutritional status is getting better. And then if we look at the freeze levels by categorical analysis, we can see that between the 2-time nutritional counseling, being able to eat for the oral food intake increased from 3.4 to 26.6. And the non-oral feeding decreased actually from 41.1 to 16.0%. So this is some of the nutritional parameters we observed during their hospitalization. And in the morning, the Canada speaker talking about the very well-established nutritional screening and also assessment and the implementation programs. But as a dietitian in Taiwan, I'm very sorry to say, we do not have manpower, and we have done our best. And then because it really takes a lot of dietitian manpower to very extensively and aggressively to take care of nutritional problems. And at this observational period, these are the nutritional indicators we will be able to observe their improvements. And other things that I would want to bring is the effectiveness of using the texture-modified diets. Many health professionals are aware of benefits of providing a texture-modified diet. But however, we have to know that some meta-analyses have shown that consumption of texture-modified diets sometimes demonstrate a poor intake compared to a regular diet. This could be also observed that texture-modified diets recipients have more malnutritional problems and also muscle mass loss than those on a regular diet. Because when we want to make the texture-modified diets, you have to put the thickening agent in it. You have to put water in it. So in other words, the nutritional density and also the caloric density is going down. So if the patient are on the texture-modified diets and without properly nutritional counseling by dietitian, the worsening of nutritional status is possible. So this is the point that I want to bring, because the preparation of the texture-modified diets really takes some time for dietitian to teach our patients or caregiver to be able to prepare at home or after they are discharged. So to conclude the small study, this is the summary. The trends of worsening of weight and oral intake status were significantly correlated with the malnutrition score. The second one is that our preliminary results demonstrate interdisciplinary team care and the nutritional counseling during the short time hospitalization may be beneficial to improve the malnutritional status and also progression of the food texture in post-stroke patients at the risk of dysphagia. And we also follow our patients for their NG removal rate after 3 months. And in our hospital, approximately 50 to 60% of the NG removal had been consistently observed, like every year. And we are looking at better methods to remove the NG tube for the long-term goals. So actually, prospective study is very, very much needed to enable to examine whether the interdisciplinary team care, including dietary intervention, can impact the long-term quality of life in the stroke patient and also improve their oral intake and nutritional status. Thank you very much. Thank you.
Okay, Dr. Huang, thank you for your literature review and your experience sharing. Now we have listened 3 very interesting speeches, and 2 speakers are still available here. So they would like to entertain any question and comment from audience.
I have a question to both 2 speakers. So texture-modified food are very important because of the safety for the dysphagic patient. But the outlook does not stimulate appetite. They don't look delicious, in most of the case. So any approach to increase the appetite when you provide textured food to the patient with dysphagia? That's my first question.
Yeah, Peter, I would like to answer first, and then Dr. Huang.
Yeah, thank you for that question. And in fact, part of what we've done with the ITSE terminology and the testing methods, descriptiveness of the characteristics is actually now encouraging culinary sciences to start looking at how to make texture-modified foods much more appealing. I know for a fact that even here in Taiwan, the Food Industry Research and Development Institute, they're working with industry partners to start looking at texture-modified foods that actually look like real foods. I had the privilege of being in Hong Kong recently, working with a few of the food industry partners there. And it's amazing. I had texture-modified dim sum that actually looked like dim sum, right? And it was so tasty. But the food actually melted in your mouth. And I think that's part of our challenge. So often we see the studies that have been done, and particularly studies that were pre-IDDSI. And I don't want to, just ring our own bell or toot our own horn. But I think that we really need to start looking at food and how it can be more appealing, higher calorie and protein density, and looking at different ways of doing things. I think, I'm sorry to say, the North American influence on texture-modified food has always been take something, put it in a blender or put it in a chopper, and then serve it to someone. It looks awful, right? And so we really need to start thinking about the making of the food in a different way. What ingredients do we start off with, right? The process that we go through in preparing the food, the cooking methods may have to change, right? And so ultimately, I don't know, I'm trying to be really optimistic because I'm getting older, and I hope somebody doesn't serve me something that's just put into a blender and put in front of my face, because I think I'm going to be like my grandma and I'm going to say, 我吃屎了, huh? Yeah.
Okay, Dr. Huang, you have any short comment, please?
I know in some of the long-term care in Taiwan, they do mix all the standards, all the ingredients, and put into the blenders and mix everything together. The flavor and the look are actually awful. So the first, you have to cook the individual meal first, and then separate cooking, and then put them on plate with a good appearance. And then I think something like lemon or like 梅子 to stimulate the saliva secretion may also increase the appetite of our patients. And the most important thing, they have to have a caregiver who are willing to take care of them. So the food industry actually, I think, play a very important role to make these foods more accessible, just like Japan. They have a different package of the dysphagia diets that you can purchase at the convenience store.
Okay, good. So,
actually, Japanese
a short question.
Oh, sorry. Japanese industry actually developing some texture-modified food in a collaboration with very famous cook. So it looks very delicious. So.
Okay.
Very nice.
Perhaps one last question. Yes.
Hi, this is Qiao Zhen. I have a question for Dr. Lan. We are trying to measure the food texture objectively. For liquid, the syringe method is okay. It's easy to measure and easy to teach a family or caregiver. But for solid food, so far we are trying to use fork and spoon, but there are some method called texture profile analyzer, and we use this machine to measure the food. But there are several characteristics such as hardness, thickness, elasticity, etc. So which indicator will be more appropriate to define the level of food close to IDDSI?
Yeah. Thank you for that question. And it is something that we are continuing to work on with food industry partners. In fact, one of the texture analyzer companies have developed, believe it or not, attachments that simulate a fork pressure test, a spoon tilt test, a puncture test. And I think one of the things that we have done so far is to try to see how do we simplify some of those testing methods. So I'll just simply talk about one. So that fork pressure test, when we're looking at how much do we push on something. And again, thanks to some of the research that's come out of Japan, where we use a kitchen scale to look at how much weight we're generating on a defined particle size of food. And what we found is if you are generating anywhere between 390 grams and 410 grams, on the scale, on a kitchen scale, you in fact are exerting about 17 grams of pressure, and so, or 17 kilopascals of pressure, and that simulates that tongue palate pressure that I had described. So we're trying to be more objective for someone using this at home, and we are working on, and more to be revealed, okay, on adhesiveness, the characteristic of, how much should actually come off that spoon in order to call it a pass on a spoon tilt, right? The particle size is easy because even on our testing reference cards that you find on our website, we've got those measures for you. So it's, 15 millimeters, 8 millimeters, 4 millimeters, 2 millimeters. But I think, again, my encouragement to the group here, more research is required. ITSE, we will always be the first to say it's not perfect, but it's a standard, and it's helped us to anchor somewhere where everybody is using the same standard. And because we're using the same standard, we can start to have a closer look at physiological impact of swallowing. We can start to have a closer look at, industry, research and development. We can start to also have a much closer look now at nutrition intervention, because that was not one of our parameters when we first started this initiative. And I think it's so important that we need to prove people wrong, to say texture modified food does not have to equal malnutrition risk, right? We all go to very expensive restaurants where they serve us, Michelin star restaurants. They serve us foam and they charge us hundreds of dollars for it. But that's liquidized, level 3, okay? And yet we pay like $150 for one little spoonful. So why can't we start thinking about culinary sciences? Why can't we start thinking about making things appealing? And I don't know, maybe someday we might actually stimulate appetite from sight, from sounds, from smell, because it's so multifactorial. And I think I'm hoping by the time I get there, there'll be beautiful food in front of me for me to eat. Yeah.
Okay, Peter, we reserve the last question to Professor Sentacher. Yes.
Right. Thank you so much. I have a question for Professor Meng-Chuan. One of the most common causes of poor oral intake of older people in the hospital is adverse drug reaction or polypharmacy. So when you go to see your patient in the hospital, do you regularly look at the drug? And if so, how do you communicate with a doctor who prescribes that drug?
You mean with amount of nutrition?
Yes.
We use the percentage of recommendation. Percentage of the recommendation. If for a patient or if the patient are referred by doctors or are at the severe malnutrition risk, normally the doctor will refer to dietitian. So we use the intake amount divided by recommendation as percentage to inform our doctors the achievements of the intake level of our patients. I do not believe that the doctors are familiar with all the absolute numbers calculated by dietitians, but in our hospital, when we use the percent of recommendation, our doctors can communicate with us well. And if our doctors need some like trace minerals or some vitamin assessment, most of the time they call us. Sometimes they want us to estimate the sodium intake or maybe calcium intake levels. We all use the percent of recommendation, provided also a solid guidelines for doctors to be able to understand.
Okay, thank you for our two speakers. Let's give them a big hands again.
Thank you so much.
So we are running out of our time. Our tasty lunch is waiting for us, right?
And before we conclude this session, we would like to express our gratitude to our speakers for the insightful presentations and the discussion. So could we invite Professor Xu and Professor Yang, representing the NHRI, to express our gratitude? And we prepared a certificate and a small gift to our speakers. Okay, thanks for demonstrating the breakthroughs achieved over the years. And let's see the cameraman.